And this is a figure or earliest stages of epidermal neoplasm, such as actinic keratosis, arsenical keratosis, or Bounce disease. Now we will shift to the tumors of surface epidermis. The tumors of surface epidermis are either benign, precancerous in situ, or carcinoma. The benign has no anaplastic cells, as we said. The precancerous, it has anaplastic cells but respect dermoepidermal junction. The carcinoma, it is anaplastic cells, but it invades the dermoepidermal junction with metastasis. The benign tumor examples: seborrheic keratosis, keratoacanthoma, epidermal nevi, cutaneous cysts, warty disc keratoma, clear cell acanthoma. And the precancerous in situ: solar keratosis, precancerous leukoplakia, oral florid papillomatosis, Bounce disease, and erythroplasia of Kira, or Bounce disease of the glands. So the precancerous in situ, there is mostly the solar keratosis, 20%. And there is 3 around 10%, the other 3. And the most erythroplasia of Kira is 30%. So solar keratosis 20%, precancerous leukoplakia about 16 to 17%, oral florid papillomatosis 10%, Bounce disease around 5 to 10 or 5 to 12, 11%, and erythroplasia of Kira is 30%. Carcinomas like Paget's disease and squamous cell carcinoma. So the tumors of surface epithelium, either benign, precancerous in situ, and carcinomas. The benign has no anaplastic cells. The precancerous in situ, it has anaplastic cells but respect dermoepidermal junction only in epidermis. The carcinomas, they have anaplastic cells but with penetration of dermoepidermal junction and metastasis. Benign tumors: seborrheic keratosis, keratoacanthoma, epidermal nevi, cutaneous cyst, warty disc keratoma, clear cell acanthoma. Seborrheic keratosis, keratoacanthoma, epidermal nevi, cutaneous cyst, warty disc keratoma, clear cell acanthoma. Precancerous in situ: solar keratosis 20%, precancerous leukoplakia and oral florid papillomatosis about 10%, Bounce disease 10%, 5 to 11, and erythroplasia of Kira 30%. Shift to the squamous cell carcinoma. The carcinomas like squamous cell carcinoma and Paget's disease. The first benign tumor is the seborrheic keratosis. So we will talk about the seborrheic keratosis. We'll start about the benign tumors. Seborrheic keratosis, as we said, keratoacanthoma, epidermal nevi, and cutaneous cyst, warty disc keratoma, clear cell acanthoma. The first is seborrheic keratosis. Seborrheic keratosis, or basal cell epithelioma, it is a common benign epidermal tumor characterized by one or more sharply defined light brown to black, slightly raised lesions as if stuck on the surface. Most of them have soft velvety or finely verrucous surface, maybe with keratotic plugs. And this is a figure of inflamed seborrheic keratosis. Inflamed seborrheic keratosis. So this is the keratoacanthoma. It's a rapidly growing self-healing epidermal tumor, striking resemble clinically and histologically to squamous cell carcinoma, proliferative, mature, and involutional, and it's firm color to pink dome-shaped horn with horn-filled center, and it reaches full size within 6 to 8 weeks and volute within 6 months with slightly depressed scar. As we can see here, this is a picture of keratoacanthoma, and we see the resemblance also to squamous cell carcinoma here. And we see here this picture of keratoacanthoma. Mature keratoacanthoma. And regressing keratoacanthoma, and this is giant keratoacanthoma. This is also giant keratoacanthoma. multiple keratoacanthomas and subungual keratoacanthoma. We can see here the histopathology of keratoacanthoma, showing symmetric epithelial tumor with central necrotic center or crater surrounded by epithelial lipping. And also here we can see mature keratoacanthoma. This is another figure of keratoacanthoma histopathology, involuting with the proliferating fibroblasts in the papillary derms. And this is a keratoacanthoma low magnification with the epithelial lipping, keratin-filled crater and lymphocytes in the derms. And also this is keratoacanthoma high magnification with keratin-filled crater and glossy squamous proliferation. Now I remind you of the benign tumors of surface epidermis. We took the seborrheic keratosis, keratoacanthoma. Now we will talk about epidermal nevi and cutaneous cysts. Epidermal nevi, they are circumscribed hamartomatous lesions composed of keratinocytes. They present usually at birth or shortly after. The epidermal nevi, so they are since birth or shortly after, follows lines of Blaschko, usually warty on the trunk and linear on the extremities. So there are two types: the localized type nevus unitus latiris and the systematized type ichthyosis hystrix. Localized type nevus unitus latiris, it consists of closely set verrucous papules, flesh-colored or brown color, may be located anywhere, only on one side of the patient. On the extremities is longitudinal, on the trunk it is usually curved. Differential diagnosis from linear lesions linear lesions like lichen planus, linear psoriasis, lichen striatus, linear Darriere disease, etc. And ELVN. ELVN differs clinically by the presence of inflammation, erythema, and pruritus, and histologically by the presence of inflammation and parakeratosis. So the ELVN differs from the LEVN by clinically by the presence of erythema and pruritus, histologically by inflammatory infiltrate and parakeratosis. Usually we ask, is it itchy or not? If it is not itchy, so it is lichen planus or ELVN. If it is itchy, it is lichen planus or ELVN. It is not itchy, it is lichen striatus. So it is not itchy, lichen striatus usually. If it is itchy, then it is either lichen planus or ELVN. We ask when it did start. If it is since birth, so it is ELVN. If it is not since birth, usually it will be lichen planus. This is a differential diagnosis of ELVN or localized type nevus unitus latiris, and systematized type ichthyosis hystrix. The ichthyosis hystrix, it is bilateral and symmetrical distribution of widespread linear lesions. Differential diagnosis from incontinentia pigmenti, and basal cell carcinoma and less commonly squamous cell carcinoma rarely develop in the epidermal nevi. There is association with congenital skeletal and CNS anomalies, mental retardation, epilepsy, usually in systematized epidermal nevus. So the epidermal nevi, either localized type nevus unitus latiris or systematized type. We can see here the figure of nevus unitus latiris, epidermal nevus affecting one half of the body. And also here we can see the ELVN, inflammatory linear verrucous epidermal nevus with erythema and scaling. And this is the histopathology of the epidermal nevus, showing hyperkeratosis, acanthosis, papillomatosis, and elongation of rete And there is differentiation about that in this histopathology towards seborrheic keratosis and epidermal nevi, hyperkeratosis, acanthosis, and papillomatosis. The treatment, sometimes we use erbium laser. The nevus comedonicus It is closely set, slightly elevated papules that have their center dark, firm, hyperkeratotic plug resembling a comedo. Nevus comedonicus usually has linear configuration, occurs as a single lesion, but sometimes it could be multiple bilateral linear lesions or lesions that randomly distribute rather than linear. Lesions may be present on pulse and soles also. Histopathology, each comedone comedo is presented by wide, deep invagination of the epidermis filled with keratin. Treatment either by comedone extraction, retin A, salicylic acid, reassurance. The nevus comedonicus also, it is nevus, so it may be dating since birth or shortly after in childhood. You can see here figure of nevus comedonicus with closely set comedone-like papules. And this is the histopathology. Epidermal hyperplasia with increased number of sebaceous glands. And the comedo wide deep invagination of the epidermis filled with keratin. This is a picture of epidermoid cysts, dome-shaped protuberance of the skin, and histopathology epidermoid cyst, which has stratified epithelium with granular layer. And inside there is keratinous material arranged in laminated layers. So this is clinically, as we can see, the epidermoid cyst, and histopathologically with the lining epidermis containing granular layer, and there is laminated keratin in the inside. Here the tricholemmal cyst or pilar cyst, which resembles the epidermoid cyst but usually occurs in the scalp clinically, and it differs histologically that it lacks the granular layer. As we can see here, this is the epidermoid cyst, the cyst lining with granular layer and laminated keratin, filled with laminated keratin. And this is the pilar cyst, where the cyst lining without granular layer and compact keratin and some calcification. And this is another picture of pilar cyst, no granular layer in the cyst wall, and compact keratin inside the cyst. The milium, the primary here, one picture of a primary milium. Steatocystoma multiplex, multiple yellow cystic lesions on the trunk, and histologically, sebaceous gland is present in the cyst wall, empty cyst, and usually it is folded. There is eosinophilic cuticle with protruding irregularly into the lumen. Also, this is histopathologically with the steatocystoma multiplex. It is an empty cyst lined with this is the eosinophilic cuticle and sebaceous gland on the wall. And also you can see here, this is the high magnification, the empty cyst and cellulated eosinophilic cuticle of steatocystoma multiplex. Cutaneous cysts, there is the epidermoid cysts, milia, steatocystoma multiplex, and pilar cyst or tricholemmal cyst, dermoid cyst, eruptive villus hair cyst, bronchogenic and thyroglosal duct cysts, cutaneous ciliated cyst, median raphe cyst of the penis, and eruptive villus hair cyst, and hydrocystoma, apocrine hydrocystoma. The pilar cyst only we will talk here about. It's clinically like epidermoid cyst, but usually on the scalp, and histopathologically it's the same but no granular layer. The hydrocystoma, the apocrine hydrocystoma, common translucent to bluish cyst, usually occurs in the eyelids or sometimes elsewhere, and the cyst appears empty. Histopathologically it appears empty because the fluid leaks out. The cyst lined with cuboidal or columnar epithelium with two layers. So the cyst appears empty with because fluid leaks out, and the cyst is lined with cuboidal or columnar epithelium with 2 layers. This is the common apocrine hydrocystoma, low magnification. We can see the empty cyst and we can see 2 layers of the columnar or cuboidal cells. Here also, but here it's pigmented. So there is pigmented sweat inside. And this is high magnification. We can see apocrine secretion and cilia and the 2 rows of the columnar or cuboidal cells. So the tricholemmal cyst or pilar cyst, it is keratin containing cyst. They are firm, smooth, round nodules occurring mainly on the scalp, indistinguishable from epidermal cyst. However, less common, autosomal dominant inheritance, sometimes and easily inoculated. Histopathologically, the wall resembles external hair root sheath, shows distinct palisading of peripheral layer and swelling of the cells close to the cystic cavity. The content of the cyst consists of homogeneous horny material. So it is show epithelial lining that lacks the granular layer and it's keratin containing cyst. And there is compact keratin inside the cyst. The dermoid cyst, rare congenital, it results from sequestration of the skin along lines of embryonic closure. They appear as subcutaneous cysts, usually present at birth, commonly on the head, around the eyes, nose, and the neck. Lateral eyebrows. Histopathologically, in contrast to epidermal cysts, they are lined with epiderms that possesses various epidermal appendages. So the lining epiderms contain various epidermal appendages. This is the dermoid cyst. As we saw first, the pilar cyst, no granular layer, pale keratin and compact keratin inside the cyst. And here this is the dermoid cyst. With the pilosebaceous unit here obvious. Other cysts like villous hair cyst, as we can see here, with villous hair inside laminated keratin, and this is the villous hair cyst. And also there is the thyroglossal cyst, thyroid follicle cyst lying in germinal center, thyroglossal cyst, high magnification, pseudostratified columnar epithelium and cilia, a thyroid follicle, thyroglossal cyst, high magnification. And also there is the brachial cleft cyst, squamous epithelium, columnar epithelium, and lymphocytes. Brachial cleft cyst, low magnification and high magnification. You can see the globlet cells inside and lymphocytes. Reminding again of the benign tumors of the epidermis: seborrheic keratosis, keratoacanthoma, epidermal nevi, cutaneous cyst, and now we will talk about briefly warty disc keratoma and clear cell acanthoma. The warty disc keratoma, solitary elevated papular nodule with keratotic umbilicated center, usually occurs in the scalp, face, and neck, and occasionally sun-exposed area, trunk, oral mucosa. And clear cell acanthoma, solitary, slow-growing, red-crusted, stuck-on nodule on with peripheral collarette of scale on the legs usually. And here the most important, that the epidermal cells, except the basal cells, appear clear because of the presence of large amount of glycogen due to absence of phosphorylase. This is the histopathology. So the two other warty disc keratoma and clear cell acanthoma. and we will see here histopathologically of the clear cell acanthoma, the warty diskeratoma and clear cell acanthoma, warty diskeratoma, cup-shaped invagination of the acanthotic epidermis and acantholysis, warty diskeratoma, and clear cell acanthoma, well circumscribed epidermal tumor with composed of clear glycogen-rich cells. Clear glycogen-rich cells. Here there is a note about the cutaneous horn. It is a non-specific reaction pattern that appears as conical hyperkeratotic lesion of various sizes, and different types of lesions can be seen at its base. Like we here have this differential diagnosis of either benign lesions like seborrheic keratosis, wart, premalignant solar keratosis, and malignant squamous cell carcinoma. So the cutaneous horn could be benign seborrheic keratosis, wart, or it could be premalignant solar keratosis or malignant squamous cell carcinoma. We can see here a picture of the cutaneous horn. Another note about pseudocarcinomatous hyperplasia or pseudoepitheliomatous hyperplasia. It presents marked downward proliferation of the epidermis into the dermis, simulating squamous cell carcinoma. Occurs in chronic proliferative inflammation and chronic ulcers. Chronic proliferative inflammation like bromoderma, blastomycosis, pyoderma vegetans like blastomycosis like pyoderma and pemphigus vulgaris, and hidradenitis suppurativa. And chronic ulcers, example burns, stasis dermatitis, pyoderma gangrenosum, basal cell carcinoma, lupus vulgaris, scleroderma, gamma, granuloma inguinal. The histopathology, it resembles squamous cell carcinoma grade 1 or 2. There is irregular invagination of the dermis by epidermal cell masses and strands of horn pearl formation. However, squamous cells are well differentiated, atypicalities are minimal or absent, and the epithelial strands may be penetrated by inflammatory cells, a feature not seen in malignancy, and findings of the original disease could be found. So it's well differentiated, no atypia, and there is inflammatory cells. So it represents marked downward proliferation of epidermis into the dermis, simulating squamous cell carcinoma. Occurs in chronic proliferative inflammation like bromoderma, blastomycosis, pyoderma vegetans, blastomycosis like pyoderma and pemphigus vegetans, hidradenitis suppurativa. Chronic ulcers like burns, stasis dermatitis, pyoderma gangrenosum, basal cell carcinoma, lupus vulgaris, scleroderma, gamma granuloma inguinal. Histopathology resembles squamous cell carcinoma grade 1 or 2, irregular invagination of dermis by epidermal cell masses and strands, also horn pearl formation, but squamous cells are well differentiated, no atypia, and also there is inflammatory cells, and also there might be the original disease findings may be found.